And let's see, I show the time is 6 o'clock. So welcome to all of those of you who've been able to join us this evening. We're thrilled you're here. This is the Genetics of DCM webinar, Hope for the Future. Tonight's webinar is brought to you by the Dcm Foundation in partnership with our wonderful sponsor, Pfizer. I am Jan Rock from the Dcm Foundation, and I will be your host tonight, along with the amazing Heather Musgrove, who will be operating all of technical aspects of the webinar behind the scenes. We will begin tonight's presentation right at 6:01. We've had a number of registrants. I want to give them an extra minute to join. And a couple of housekeeping items this evening. Please note that all participants are automatically muted during the webinar so that we can hear the speakers clearly. Also, if you have any technical issues during the webinar, please use the chat feature at the bottom of your screen and Heather will assist you. If you have questions, we ask that you use the Q&A box at the bottom of your screen for any questions you have, of course, during the presentation. And as always, we encourage you to visit our website at dcmfoundation.org for updated information and resources related to dilated cardiomyopathy. One final note, I would be remiss if I didn't say happy St. Patrick's Day to those of you who celebrate. Being half Irish, I am proudly wearing my green and my little shamrock pin. This is from years ago. Again, thank you for those of you who've just joined us tonight. We're going to get rolling. Everyone's microphones are on mute. If you do have any issues tonight, just put them in the chat box and Heather Musgrove will help you. Otherwise, let's get rolling. So the Dcm Foundation was founded in 2017. Our mission is to provide hope and support to patients and families with dilated cardiomyopathy through research, advocacy, and education. And what I'd like to do is put up our first poll tonight. Heather, if you could do that for us, just to get an idea of who's attending tonight's presentation. Just select the answer that best represents you. If you're a patient, family member, medical provider, or interested for another reason, we'll give that just a minute here. It's always great for us to see who's on with us tonight. Great, we have a nice mixture. Excellent. We'll leave that up for just a quick moment. Okay, good. I think we can share the results now. And so we do, we have a nice mixture. We typically see about 50% of the folks on are patients. So that's wonderful. We're seeing that as well as family members and medical providers. So that's fantastic. Please note that all of our polls are anonymous, so you can rest assured with that. So without delay, I am happy to introduce you to our president of the Dcm Foundation and also a Dcm patient, Greg Roof. Greg, you can take it away.
Jan, thank you. I would like to thank everyone that's attending this evening's webinar, taking the time out of your busy day to be with us. Tonight's presentation is, no pun intended, really close to my heart. My family, was diagnosed 7 years ago with dilated cardiomyopathy due to the Lamin genetic mutation, which is what this evening's presentation Pfizer will be showing us and presenting us. Not only do I have the genetic mutation, but also 8 living family members have it, and several have died of heart disease due to DCM from the Lamin genetic mutation. And as you can see, the 2 very young members of my family to the left and the right of the screen each have a 50-50 chance of having the Lamin 331 gene. So what we're discussing tonight is really important to me, my family, the future of my family, and we encourage you all to participate and help in this fight against the Lamin DCM. Jan? So why should you get genetically tested? Why is it important? One of the things is, if you have DCM and your cardiologist, your doctor doesn't know what caused it, I think, my personal view, I am not a medical practitioner, but my personal view is if anybody has DCM from an unknown cause, they should get genetically tested to see if they actually have the, a genetic predisposition to this. And why is that important? If you have a genetic predisposition to DCM, potentially family members could have that. And it's really important if you get tested or positive that they get tested, because if they test positive for a gene mutation, they then can be put under care and watched, so that if their disease starts to show up in the very, very early stages, they're able to actually slow the disease, which gives them a much longer and a higher quality of life. Also, there's a strong connection between DCM and pregnancy for women that have DCM or genetic predisposition. So it's really important for them to understand if there's any connection at all. And then I think lastly is that by being genetically tested, and if you or family members have tested positive, you then have, and it's fully optional, but you have the option of being able to get in research studies like Dr. Ray Hirschberger's, who's on the board, the DCM project study, or be able to get into a clinical trial that Pfizer will be talking about before, because the more people that we have to put into tests, the quicker that we'll create and be able to create solutions for DCM.
You want to put up the second poll, Heather? That would be great.
Yeah, we'd love to understand who has been genetically tested. So please answer that question, and we'll take a look at the results.
We have about 65% that have voted. We'll give everyone about 10 more seconds to go ahead and select.
Again, this is anonymous, so you can feel free to vote.
Great.
All right, we'll go ahead and close that poll now.
Looks great. Thank you for participating. 44% yes, 33% no, and 23% not applicable. So thank you for doing that. One of the things, two ways to get tested genetically if you suspect your DCM as of a genetic nature. Last slide, you can go to your cardiologist or doctor and ask to be genetically tested. You can also get tested yourself. You can go directly and get genetic testing without a medical prescription for it. And we have a partnership with Invitae where you can actually go as an individual to get genetically tested. In our partnership with Invitae, there are two options. There is a free option, but you'll need to spend a little bit of time filling out some survey information and information about yourself. If you're not interested in doing that, but you're interested in getting tested immediately without filling information out, there's a pay option, and I believe I just did it a few months ago. It was $250. Not sure that's the exact price, but it's fairly inexpensive in the world of medical testing. They send a kit to your home. You simply spit in that test, shake it up, send it back, and then part of your $250 fee is that you actually get 2 consultations, pre and post results of your test to be explained by a licensed genetic counselor. Again, you can see the link that's up there. You can also go to just dcmfoundation.org, and on our home screen there is a genetic testing button. Jan? Last but not least, really would like to thank Pfizer for tonight's presentation and being a generous sponsor of the DCM Foundation. And we really appreciate them helping us here at the DCM Foundation better support patients and families with DCM. Jan?
Excellent. Thank you so much, Greg. And I am thrilled to present tonight's speaker, Dr. Callum Mcrae from Brigham and Women's Hospital. Dr. Mcrae is a well-known cardiologist who's been working on clinical, translational, and basic genetics of cardiomyopathy for 25 years. He is a professor at Harvard Medical School and vice chairman of medicine at Brigham and Women's Hospital in Boston. He's also the former chief of cardiovascular medicine at Brigham and Women's Hospital and director of cardiovascular genetics at Massachusetts General Hospital. So without further delay, I am pleased to present Dr. Mcrae. The floor is yours, and I will stop sharing my screen and you can share yours.
So Jan, thank you very much to you and Greg for the introduction, the opportunity to speak, and I look forward to talking this evening about lamin-related dilated cardiomyopathy, a disease that also is close to my heart. I was part of the team that described the original families with lamin-related dilated cardiomyopathy and have looked after many of the largest families for the last 20 years or so. I am just going to get my pointer sorted out and then we'll get started. I'm going to talk this evening really in three broad areas. I'm going to introduce you to dilated cardiomyopathy in general, some specific information on lamin-associated dilated cardiomyopathy, which, as I'm sure many of you know, has some unique features, and then introduce the Array 797-301 clinical program, which is a randomized trial to understand the effects of this compound in individuals with lamin-associated dilated cardiomyopathy. You've heard too much about me already. Let's move straight on to the topic in hand, dilated cardiomyopathy. So, as many of you, and particularly in this foundation, are aware, dilated cardiomyopathy really is a large group of diseases. It is essentially a diagnosis of default when you've excluded other causes of disorders of the heart muscle. And that's typically eliminating high blood pressure, eliminating valve disease, eliminating blockages in coronary arteries. Typically, those individuals will have enlarged and weakened hearts. And while maybe 25, 30 years ago, it was thought that the majority of dilated cardiomyopathy was caused by viral myocarditis burning out, it's now, as Greg alluded to, it's now known that the majority of this is due to either mutations in genes that are inherited through families or mutations that arise in a single generation. So as he mentioned, the fact that you don't have an extended family history is not in itself a reason not to get genetic testing, since it's still far and away the most common cause of dilated cardiomyopathy. It is one of the leading causes of heart failure worldwide, and about 30% of all heart failure hospitalizations in the US are caused by dilated cardiomyopathy, but it tends in general to affect younger individuals because of this inherited predisposition. It's less typically in the elderly population where coronary disease is more common. And it is still far and away the most common indication for heart transplantation. About 65% of those under 40 and about 50% of the remaining groups with heart transplant. The clinical signs and symptoms are very much, as you can see on the right-hand side, those of traditional heart failure. The pressures inside the heart are elevated. There's backup into the lungs, and the heart is under significant undue stress, and that can often lead to symptoms of what we call sympathetic activation. You feel as if you're active even when you're not. Your entire cardiovascular system is remodeled. Typically, the echocardiographic imaging that we use to screen for heart failure causes is abnormal from the very first time that patients are seen. But if you're, as Greg alluded to earlier, if you have a mutation, you may not yet have developed the disease. And in fact, only a percentage, a significant percentage, but not every single person who has a mutation will ultimately develop the echocardiographic features, which are enlargement of the heart, thinning of the heart muscle wall, and a reduction in the ejection fraction, the number that people use to quantify how effective your heart is at contracting. The symptoms, as I mentioned a second ago, are typically those of general heart failure. You will often get chest pain. That's actually, interestingly, even by cardiologists, less well recognized as a feature of cardiomyopathy, but it is still one of the most common features of cardiomyopathy. You'll typically have palpitations at times, and occasionally people will present actually with loss of consciousness, or dizziness or lightheadedness, because the heart is racing and the contraction is ineffectual. On the pulmonary side, in the top right-hand corner, these are also very common symptoms with shortness of breath, or dyspnea as it's called, wheeze, blood-tinged sputum, and cough. Classically, these will come on with exertion or when you're lying flat. But oftentimes, even quite significant heart failure can be missed in younger people until it gets really quite severe, because they tend to compensate for some of these features. And so one of the classic presentations in younger individuals is when the right side of your heart starts to have elevated pressures. And then your entire bowel will be congested, your liver will be congested, you'll have reduced appetite, sometimes pain in your abdomen, bloating, constipation, diarrhea. Both of these can occur. Your abdomen will swell. You will tend to pass urine overnight, and often will also feel very prone to passing urine after lying flat for a short period of time, because your body will clear fluid more efficiently during those periods. You will often have reduced libido, feel less active in your sex life, and it can often be quite a common cause of erectile dysfunction. All of these things are features of, in first instance, right heart failure, and then more general reduction in your cardiac output. And then all of these things can contribute in a lot of different ways to the other symptoms, the more miscellaneous symptoms, although they're very real for lots of people: dizziness and lightheadedness, disturbed concentration, inattention. Fatigue is often a very common early symptom. Sweating, that's the sense that you're active and exercising even when you're not doing anything, because your sympathetic system is so elevated. You'll get leg swelling when the right side of your heart fails. And then skin alterations, visual and hearing impairment are very common. There are some other features that are seen in different types of cardiomyopathy, and Lamin AC-related cardiomyopathy is one of those. And there's actually symptoms of multisystem disease. Very typically, there are abnormalities, even subtle abnormalities of your limb girdle, your shoulders and your hips. And often, if not always, if you look hard enough for it in Lamin AC-related cardiomyopathy, there is also some mild peripheral neuropathy, which leads to a gait disturbance in combination with the limb girdle weakness. The impact on patients' quality of life is quite diverse. Your overall physical functioning starts to decline. You're limited physically. That leads to a whole host of stresses. The elevation of your sympathetic nervous system will often make you quite agitated or emotional at times. You don't function as well socially. The general feeling of debility and tiredness obviously affects mental health, perceptions of your overall feeling of health, and your general vitality. And then sleep is typically very disturbed, even in individuals who don't have overt shortness of breath when they lie flat. So all of these things are part of a general syndrome that we label as heart failure. Genetic mutations, as I mentioned, are typically the most common cause of dilated cardiomyopathy that we can so far identify. When we look at family structure, we see that the majority of individuals who have dilated cardiomyopathy have some family history of it, but we can still only identify actual mutations in a percentage of these. The typical genes that are involved are troponin T, TNT2, BAG3, myopotin, myosin heavy chain, and then titin you'll see in parentheses, because it typically, although it's quite a common set of mutations, they typically will require some other insult on top of them to lead to the cardiomyopathy. But perhaps the most obvious familial form is lamin AC associated cardiomyopathy, which is about 6% of all forms of heart failure and is considerably more common in a subset of the disease that I'll identify in the next couple of minutes. So lamin AC is actually a protein, very regularly spiraled protein that lines the nucleus of every cell in your body. And what it's thought to do, and we don't know fully all of the activities, but it's very important for the structure and function of the nucleus. It communicates signals from the outside of a cell to the center of the cell, where the DNA and all of the protein manufacturing machinery is located. What happens when the protein is mutated, when there's an abnormality in the gene, is it doesn't fold properly. As a result of that, it doesn't go to the right places in the nuclear membrane. It doesn't communicate the signals from the outside in or from the inside out in the right way. And as a result of that, these minor signal abnormalities accumulate over time. And the entire cell behaves, not just the heart muscle cell, but also other cells in your body, as we mentioned, behave as if they're inflamed. The signals suggest that to the machinery of the whole body that there is this chronic grumbling inflammatory process that leads to general remodeling of the way that the heart works. That leads to its impaired contraction. You get irregularities of the heart rhythm. You get weakening of the heart muscle, and then secondarily, and in lamin AC, primarily, you get weakening of the other muscles in the limb girdles in particular. So all of these are a consequence of a single base pair being defective in your lamin AC gene out of the billions of nucleotides that are in your genome. In general, there are about, when we look at it overall, we estimate there are somewhere around 49 to 50,000 people in the US with lamin AC dilated cardiomyopathy. The age of onset, depending on how you look for it, is typically in patients' 20s to 30s, although it can be quite a bit later, and it can be quite a bit earlier. I have family members that have presented when they're 10 or 11. I have family members that have presented in their 60s and 70s. Most patients will experience some cardiac symptoms before the age of 50. And typically, those are heart failure or symptoms or signs. And oftentimes, when you talk to those individuals, there's a retrospective history of irregularities of the heartbeat, which may not have been manifest in a way that led to you seeing a physician, but are typically palpitations, feeling your heart flutter. But also a significant number of individuals with lamin AC in particular have had atrial fibrillation diagnosed before there's any evidence of any other cardiac involvement. And in almost every instance, that atrial fibrillation is in the setting of what's called atrioventricular block. So you get first-degree heart block on your 12-lead electrocardiogram. And that is still the most sensitive way of identifying the clinical components of this disease. Unfortunately, lamin is typically a little bit more aggressive in some individuals, a lot more aggressive in other individuals than other causes of dilated cardiomyopathy. And so we tend to have a really high index of suspicion for lamin in certain settings, and we have a low threshold for intervening because we do know that very quickly these individuals over a period of even a couple of years will tend to progress. But not everybody does, and as Greg very wisely stated at the start, not every individual who has a mutation even will end up with any of overt symptoms from the disease. The diagnosis is typical in individuals who have this left ventricular enlargement. That's dilated cardiomyopathy in general. But the characteristic clinical features associated with lamin are early onset atrial fibrillation, the AV block, which is almost universal in lamin AC disease, although it can be quite subtle. It doesn't have to be complete heart block. It can just be first-degree AV block, and a disproportionate reduction in exercise capacity for the extent to which somebody's heart has been diminished. So very commonly, that's a result of the limb-girdle dystrophy, which is just not very well recognized. But it can also be because of the fact that your heart rate does not change with exercise in a typical fashion because of the conduction system abnormalities. The Lamin gene sequence is typically performed. We sequence every single one of our DCM patients in the Harvard system, and it's now pretty widely prevalent across most large academic medical centers. But it still can be difficult in some settings for individuals who are not used to getting sequencing to obtain it. And that's one of the reasons, obviously, that we highlighted the Invitae program at the start, where in partnership with the Dcm Foundation, it's possible to get genetic testing and the counseling appointments before and after that are so important. When we study the features, patients with the features that I described, over 99% of those with typical Lamin AC cardiomyopathy will have an identifiable pathogenic mutation in their DNA sequence. This then triggers what's called Cascade Screening, where we start to look at the extended family. Molecular genetic testing can be offered to at-risk relatives once a definitive mutation has been identified. That allows us then to counsel the patients or the family members before they get the testing, so they understand what the testing means and how to interpret it. Genetic counseling is also offered to women, obviously, ideally prior to pregnancy, so they can understand the implications. And if genetic testing is not possible, which is not unusual, even although the program is available, not every physician in the US has heard of it, not every physician worldwide has heard of these types of programs. And so at a minimum, first-degree relatives should be evaluated annually by a classic medical history and physical exam. A cardiologist will typically be able to do that, and then an ECG and an echo to screen for presence of the disease, even in its earliest forms. Again, important to note that not all carriers of a Lamin mutation will develop the disease. I have looked after one family that has over 400 affected individuals with the mutation, and there are several individuals who have not really had any complaints from the disease and have had other medical problems be the result of their eventual demise. There are only certain features of the disease present in some individuals, even if they have the same mutation. We do now recognize that the harder you look, the more you find. And so that's one of the reasons that we recommend that you do see somebody who has expertise in dilated cardiomyopathy. The treatment is typically dependent on the stage of disease. So early on in the first 20 or 30 years of life, it's usually just isolated conduction system disease, the electrocardiographic abnormalities that we talked about. The third or fourth decade, you start to see the emergence of the dilated cardiomyopathy with some symptoms of fatigue and early heart failure. And then more advanced DCM is present in the fourth decade. In some families, in males, it comes on considerably earlier, and in females, it can be quite a bit later in onset. And that's not an unusual pattern. The treatment, as I mentioned, is based on the symptoms and signs. It's in the first instance for heart failure type symptoms, it would be managed with standard therapies for heart failure. An implantable defibrillator is commonly recommended early in laminopathy because of the risk of arrhythmias. And up until now, there have been no specific therapies available for Lamin-related dilated cardiomyopathy, and that's one of the reasons we're interested, on top of the existing guideline-directed medical therapy that is for all forms of heart failure, to think about looking for compounds that might have very specific effects in Lamin-dilated cardiomyopathy or in other genetically defined cardiomyopathy subsets. And that's part of the reason why I was excited several years ago to begin to work with this compound, this Array 371797, just the name for a drug that has not yet been approved for this indication. And the clinical program was one that was started after it had been observed that in animal models with very specific dilated cardiomyopathy, that this particular drug, which inhibits a stress protein called P38 MAP kinase, was shown to improve cardiac function and lifespan in mice that had that disorder. Now, obviously, not all mice are, well, mice are not all that humans are. And so we had to then begin to explore the use of the drug in humans. And the first study was a phase 2 study, which we completed, which I was the principal investigator on, where we studied 12 patients, not in a randomized fashion, but in a dose ranging study that everybody knew that they were getting the drug. They just got it at 2 different doses. And they could agree to also, once the dosing study being completed, agree to continue on the drug if they felt it had helped them. And now what we've done, having seen the results of that first study, which I'll show you in a minute, is move to a phase 3 study where we're doing a randomized clinical trial, a formal test to understand exactly what the effect of this drug is in lamin AC dilated cardiomyopathy in 160 patients. The pilot study, as we mentioned a second ago, was really looking at the doses that could be used. And we took 12 patients who were already on maximal therapy for their dilated cardiomyopathy, already had symptoms that had broken through that particular set of medications. And we put them on both a study drug at 100 milligrams twice a day, this is the Array 797, or started individuals on 400 milligrams. And you were allowed to go from the lower dose to the higher dose if at 6 months you had still not seen a significant response. We used a variety of different measures that were specified by the FDA to assess the efficacy of the drug, obviously not in a randomized or blinded fashion yet. And importantly, despite a run-in that you can see here, where we looked at the 6-minute walk test, which people can get better at over time, even without a drug, we were able to show that when we initiate the drug, you see this significant change in the distance that people can walk in 6 minutes. And most individuals who were in the study, not everybody was able to make it all the way through the study because of other things that happened to them. One person had a transplant. One person had problems with a defibrillator that led to recurrent VT. But in those individuals who are on the drug, you can see that they maintained their functional capacity over that time. And when we got to the end, the vast majority of individuals who were still on the drug at this stage wanted to continue the drug because they had seen significant improvement, or they felt they had. But that's still obviously not a definitive test of the drug. And so we're now in the process and are actively recruiting to this study. One of the reasons that I'm here this evening is to inform you about it. It's a really well designed study where we're able, because of the specificity of the lamin AC disease, to do this study in a much smaller cohort than would typically be required for any form of heart failure therapy. Typically, the studies are 5,000 to 10,000 patients. But because we know so precisely on the basis of mutations that people have this mechanism, we worked with the FDA to get a significantly smaller study, which we believe will be much more efficient getting to the truth. We're randomizing 120 patients who have class 2-3 heart failure, so get it while they're exercising at different levels of activity. And then we're also going to include 40 individuals who have class 4 heart failure, that is symptoms at baseline when they're not exercising or active. We're randomizing individuals to get the drug or a placebo that is inactive. That's the only way to really understand whether or not the drug is truly having an effect. Everybody will be enrolled for 6 months. It will be double-blinded. Neither you nor the study physician will know which treatment you're receiving. It is placebo-controlled, as I said, so the other group will get all of their existing heart failure therapies plus this placebo, which is an inactive agent, and we won't know which are which. We'll also have an open label extension. So once the last participant is in the trial at the end, whether you were randomized to the placebo or to the active drug, you will be eligible to receive the study drug going forward. And the primary objective in this study is to evaluate the effects of the drug on functional capacity as measured by a 6-minute walk test over 6 months. And there's a whole slew of other things that we're measuring to try and understand the drug, but this was the one that was specified by the FDA. Because really the important thing for us is overcoming the symptom limitation that we see despite maximal traditional therapy with lamin-associated dilated cardiomyopathy. The primary eligibility criteria are listed here. You have to have a confirmed diagnosis of lamin AC associated cardiomyopathy. You have to be over the age of 18. You have to have had a device implanted, either a ICD or a CRT defibrillator, so either an isolated cardioverter defibrillator or one that is coupled with a pacemaker for cardiac resynchronization. You would have to have symptoms, obviously, to make it worth your while to come into this study. And there are a couple of minor blood test abnormalities which we always look for, really just because of interactions with the drug. So we're doing some blood testing to be certain that your liver and kidney function are sufficient to allow you to enter the study. There are over 60 sites in North America, Europe, and Latin America recruiting. And obviously, we're going to give you the contact information to get to the closest site. And you should feel free to reach out, certainly to me or to anybody else who's in the study, and through the Dcm Foundation indirectly to get access to the study if you are feel you're eligible for the lamin AC related trial of Array 797. How can you get more information about this trial? You're going to, I hope, get access to this information directly through the webinar, but also on the website from the Dilated Cardiomyopathy Foundation. You can call this number, 1-800-718-1021, or you can also email directly to clinicaltrials.gov_inquiries@pfizer.com. And I am going to stop there. I'm going to leave, while we're waiting for questions, I'm going to leave this slide on the screen so that you can obviously see the contact details and take those down. And I'd just like to thank the Dilated Cardiomyopathy Foundation for the opportunity to speak to you all this evening, and also thank Pfizer for their sponsorship of the trial and for their sponsorship of the Dilated Cardiomyopathy Foundation. So thank you.
Thank you, Dr. Mcrae. It was fantastic, excellent information. We have a number of questions that have come in, so let's spend a few minutes going through some of these questions. We had a couple of questions around how DCM is related to HCM and how can the same genes cause both?
So that's, I think, an excellent question. So they are both related to the way in which the heart perceives stress. And I should point out the fact that only a very small minority of genes, and only, even within those genes, only a small minority of the mutations within the genes can lead to both dilated and hypertrophic cardiomyopathy. It does happen, even in the same family. But in general, these tend to breed true. As I mentioned, the real mechanism by which it can cause either thickening or dilation and thinning of the heart is the differential response to stress. So it's thought that there are a couple of different factors in that. One, the particular type of stress that an individual's heart is subjected to. And then the second thing that I think is quite an important thing that is under-recognized is that oftentimes we're seeing patients at different stages of the same disease. So it's possible that the individuals who have dilated cardiomyopathy had hypertrophic cardiomyopathy earlier that was not fully realized. And the more that we look at these families, the more we see that that typically is actually the response. There's also a very interesting phenomenon where part of the heart can hypertrophy and part of it can dilate. And that may again be a function of the type of stress that we're seeing. So that's a general explanation. There are other possible ways in which it can happen that we don't fully understand or know about, but we're obviously looking for all of those again and again to try and understand how these different features can arise from the same mutations.
Excellent, thank you so much. How is DCM seen in an ECG?
So the DCM itself is typically not immediately obvious in an electrocardiogram. Although it's interesting with artificial intelligence, we are now finding that it may be possible, it's not yet available clinically, but it may be possible to identify individuals who do have DCM just from the electrocardiogram. However, Lamin AC disease is particularly important because of the fact that often, if not always, it is preceded by conduction system disease. So typically you will find evidence of first-degree AV block, other forms of conduction system disease in the atrium or in the ventricle. And then, as we mentioned earlier, those are often associated with arrhythmias. So in general, there is an electrocardiographic representation of Lamin, even if you don't end up going on to develop dilated cardiomyopathy, and it can occur quite some considerable time before the dilated cardiomyopathy itself arrives.
Excellent, thank you so much. Is prenatal or pre-implantation diagnosis possible?
Absolutely. If you have a definitive mutation, it is routinely offered for Lamin AC disease. Obviously, it's a very personal decision and personal choice. And to some extent, it depends on exactly what the course of that particular disease is in your own particular family. But it is in general available wherever pre-implantation genetic diagnosis is available. And obviously, we're happy also to connect people with the right services for their local district if they have questions on that.
Okay, all right, great. And kind of along the same lines, when should you start genetic testing in families?
Typically, as soon as somebody has been identified with the dilated cardiomyopathy, the individual should be, the proband, the first individual should be genetically tested. And then what we do is, if we have a variant that looks like it's really definitive, we can then use that to test the rest of the family, the at-risk family members immediately. And it's good to do that because oftentimes people may not yet have developed symptoms but have the disease. Or if not, we can actually follow, as Greg alluded to at the start, the progression of the disease and then intervene electively rather than waiting for symptoms. The other thing that's quite useful is if there's an equivocal, if the variant is not necessarily a definite pathogenic mutation, the only way to really understand that is to study the whole family and to look at how in that particular family, the variant and the disease co-segregate. So who's got the disease and who has the variant will help you understand the variant's role in the family. And so that can often be very powerful and allows us to move even beyond what's known already about individual variants in a specific family. And it's one of the reasons why the clinical and genetic evaluation really go hand in hand.
And so the person had mentioned that in HCM, sometimes they'll recommend testing as early as teenage years. Is it the same for DCM, or would you even say earlier?
I've tended not to do it much before the earliest onset of symptoms or ECG abnormalities in the family. But to be honest, I mean, I've looked after several hundred patients with Lamin AC disease, and I can only think of one who has not had an ECG abnormality by the time they are 16. So it's pretty typical for it to be evident clinically by the time you're 16 or 17. So that's usually when I will test folks, is once they're old enough to really understand what you're doing and why you're doing it, understand the family context. There are a couple of very rare families with Lamin AC disease where there is very early presentation. That is very atypical for Lamin, and in those settings we would obviously test earlier. But in general, I usually will test folks when they're toward the end of high school. That's usually a good time to do it. For people who are older than that, or for people who are at risk and there's uncertainty, it's always easier to test than not to test. It's a very straightforward thing. You can do it from a saliva specimen or from a blood specimen.
And it's always good to remind folks that there is genetic counseling available with those results.
Absolutely, both before and after, it's really important. So even if your cardiologist or your physician is not comfortable with genetic testing, directly reaching out to the Invitae program in conjunction with the Dcm Foundation but also asking to be referred to somebody who is able to then offer the genetic counseling pre and post is really important. And that's something obviously we're trying to do here, is empower patients to ask for that as well.
Yeah, that's fantastic. There were a couple of specific questions here. If you have, someone has questions about the possibility of the limb girdle systems, what kind of physician would they see to be evaluated?
So obviously, many of these are things that should be addressable by a good general internist, and most cardiologists have a very good training in general internal medicine. If there is a specific limb girdle question, then a neuromuscular specialist is typically the best person to see. So
Okay.
we often will see our more severely affected limb girdle patients are seen in conjunction with our neuromuscular colleagues.
Okay, excellent, thank you. Are there any trials coming to Australia, or is there a contact here that is best to see that understands DCM with the diagnosed lamin mutation?
So they're absolutely, I mean, to be honest, we have tried to find centers that are able to participate in this trial in Australia. We were not successful yet so far, but we keep trying. There is actually a very good genetics service in Sydney in Australia, run by a close colleague of mine who actually, she and I were the co-first authors in the original New England Journal paper, Diane Fatkin. And there's a very well integrated genetic service there. And there's actually, there are two, one at Royal Prince Alfred and one at the, sorry, the name escapes me at the moment, it'll come back to me in a second. But Diane Fatkin is the specialist in lamin-related cardiomyopathies.
Excellent, excellent. I love to see folks interested in getting tested. That's fantastic. Dear Dr. Mcrae, excellent talk. Thank you so much. Would you consider lamin-related cardiomyopathies a mechanosensing or mechanoresponse impairment? I hope I'm saying that right.
Yeah, no, I think you are. I mean, there is 100%, there is an abnormality of the way in which force is sensed by the heart. To be 100% honest, that's the case for all forms of cardiac disease, either because of an intrinsic problem or because of the way it was acquired. So I'm loath to be over specific about how you classify these things. There's always an element of mechanosensing abnormalities in every one of these. But the most important thing is that reducing the load is a mechanism for early treatment and even prophylaxis as ventricles start to dilate in dilated cardiomyopathy. So I think it is important, as you suggest, to highlight the importance of force because all of the primary therapies are related to reducing the load on the heart. So the ACE inhibitors, ARBs, and Entresto, those early therapies are all related to that. What we're really interested in, as I said, is the next generation of therapies on top of those loading conditions. How do we begin to understand how to modify the disease even when the load has already been corrected? So.
Okay, fantastic. I personally know many lamin patients with cardiac failure, but we also have calf and feet cramps. Is that common?
That's actually quite frequent, not only it turns out not only in lamin AC cardiomyopathy, in all forms of muscle disease, whether primary or secondary, so whether cardiomyopathy related or acquired in heart failure. Partly because of the fact the muscles are remodeling, even in coronary disease, you can get remodeling of the skeletal muscle. And then on top of that, there's the use of diuretics that tend to change the way in which your body manages salts, potassium, magnesium, sodium. And so all of those will tend to make you more prone to cramps. It's particularly a problem in lamin AC because of the associated neuromuscular disease, which in general tends to make you much more likely to have um, muscle cramps. Yeah.
In general, okay. Thank you. Is there any data on whether or not the typical heart failure treatment actually slows down progression, I'm sorry, if caught early?
So that's a very good question. There's no specific data in lamin AC cardiomyopathy, but we do know from retrospective analysis of the large heart failure trials that there were individuals with cardiomyopathy and AV block represented in those trials that did respond to those therapies. So in general, I think it's a reasonable first step, and it's one of the reasons we obviously have added the Array 797 on top of existing therapy, because we believe it's, first of all, if it's going to be useful, it's going to be useful as an adjunctive disease modifying therapy. And second of all, because we know that those already have been proven to work.
Okay, excellent. There's a question here about COVID. Is there any relation yet between DCM and COVID? And I'm sure that the outcomes of people with DCM who contract COVID, obviously that may be a little bit more significant than the average person.
So it's actually difficult to be 100% certain of that. There is definitely evidence. We collected these data some, almost 20 years ago when I was in London, that individuals with all forms of dilated cardiomyopathy do have an extreme response to the effects of viral illness, whether or not it's COVID in particular. We have not yet seen, I don't think, a discrete evidence that there's a discrete sensitivity in COVID for existing cardiomyopathy patients, but there's certainly their reserve is reduced, and as a result of that, it's possible they're more susceptible to some of the downstream consequences.
Okay, that makes sense. This is a good question. I think a lot of parents would be concerned with. Can children with yet unknown cardiomyopathies exacerbate their condition by pursuing athletics throughout childhood and teen years?
So that's a very good question. There is no human data to suggest that that is the case. What we have found, particularly with lamin AC, is that the types of arrhythmia that you get can be brought on by exercise, not necessarily caused by it, but they're more likely because of the triggers to be related to exertion. And so there's always a trade-off. You'll see on television, people are saying, don't exercise, definitely exercise. I have many high-level athletes in my practice who are still exercising. I think the key thing is tailoring the recommendation to the patient's lifestyle and the risk and the benefit. So you want to, no matter what the cause of your heart failure is, you want to maintain your overall cardiovascular health, because that's the reserve that you're going to need for the rest of your life. And so you certainly don't want to stop exercising completely, but you do want to be careful that you're not triggering something. And so again, this is best done in conjunction with a managing cardiologist who has expertise at this area. But there's no reason to stop all athletics. On the other hand, if I had been diagnosed with it, I would not want to begin to take up competitive sports. I would try and get the balance just right. And a lot of this is, as you will probably recognize, polarizing in the cardiology community. And you'll see some cardiologists say, don't do any exercise, and others say, you should do everything you can. The reality is somewhere in the middle and is tailored to the individual.
Okay, thank you. I think we have time for just one or two more questions here. What is the best diagnostic tool to monitor changes in the heart? An MRI, an echo, and how often should these tests be done?
So classically, the best way of doing it is echocardiography, and it's very widely available. It's a straightforward test. When you're looking for specific tissue abnormalities, MRI can be quite useful. But oftentimes after the diagnosis is made, it's not clear what additional information you get from MRI over and above an echocardiogram in dilated cardiomyopathy. In some other settings, the extent of scarring is important and it can be useful. Nowadays, because MRIs are compatible with devices, it's less of an issue as well. But an ultrasound is a very quick way of doing it, and I recommend on an annual basis or if symptoms change. And that, I think, is pretty much the general approach in the cardiology community, in particular in the cardiology genetics community. If you're at risk and you have either uncertain genetics or positive genetics, then you should be screened on a regular basis, whether you have anything on the prior exam or nothing. If you have a definitive genetic test, and I'm careful about the use of definitive, then if you're gene negative, you do not need to be screened on an ongoing basis.
Okay, all right, great. And just quickly, someone said, just to clarify, can electrical issues or arrhythmia be a precursor to DCM? I know you covered that a little.
Yeah, so there is a classic type of cardiomyopathy that occurs in a very small group of teenagers with what's called a paroxysmal junctional tachycardia, which has been reported a couple of times in lab. And there, if you ablate the tachycardia, you don't get the dilated cardiomyopathy in the vast majority of cases. Much, much more common than that is to see individuals have atrial fibrillation or tachycardia and then develop cardiomyopathy in the ventricle. The reality is, if you have atrial fibrillation, you have a cardiomyopathy to start with, unless you have some other trigger for it. And so it's tough to know which came first, chicken or egg. And at the end of the day, it doesn't change the treatment. It's been pretty clearly shown that if you reduce the rate of your atrial fibrillation, that can help your heart failure, no matter whether it came first or second. And then obviously treating the ventricle is an important piece, whether or not you have any tachycardia related to the atrial mechanisms. So for all of those reasons, I think it's a little bit of a specious argument. The reality is the majority of people who have AF have cardiomyopathy to start with, the vast majority. And so they're probably more prone to develop the ventricular forms anyway.
Okay, all right, excellent. Thank you so much, Dr.
Can I just point out for the person from Australia, the other, Diane Fatkin is at the Victor Chang Institute, which is a fabulous research institute in Sydney.
Okay, great. And I just want to remind people that this recording will be available on our website within a few days, as soon as we do any editing that's needed. We will also have a Spanish version of this available for folks as well. So thank you so much. I am going to now share my screen again. Dr. Mcrae, thank you.
Very well. Thank you for having me.
Fantastic. And again, if you are interested in learning more about this trial, please contact a Pfizer clinical trial representative to learn more. The phone number and the email address are on the screen. The phone number again is 1-800-718-1021. The email address is there, and we'll put that in the chat as well. Also, I just want to let you know that all of this information is also going to be emailed out along with the recording of the webinar. So if you didn't catch it here, don't worry, we will be sending that out along with a link to a Spanish recorded version of the webinar that's done by Dr. Garcia. We're thrilled about that. We'd also like to put up our final poll of the night, if you folks are so willing. And as a DCM patient, what are your preferences for being contacted regarding clinical trials? And this is really going to be helpful for us to know, what are the best ways that you're interested in being reached? Directly via the clinical trial organization's marketing or outreach, notification via my doctor's office, notification via some central online resource like the DCM Foundation, or via the genetic testing company. And, maybe a little difficult to think of quickly at the moment, but again, this is really helpful in our understanding of how folks are interested in learning about clinical trials. So we'll leave that up for another 10 seconds or so. Again, thank you again tonight for joining us. It's actually still light here in New Hampshire, which is shocking. So that's fantastic. That's very, very helpful for us all. Thank you. I would just like to let everyone know that we will have our next DCM Foundation webinar on Wednesday, April 28th at 7 p.m. That's a slight change from our normal. We normally do the third Wednesday of the month, but this will be the fourth Wednesday of April. And it will be about navigating financial and insurance issues as they relate to DCM issues. So thank you again for attending. As I said, a recording will be available within a few days, and we'll also send the link to the Spanish version. It may be up to a week before we send that out, just to make sure that we roll up all the information that you need. To learn more about the DCM Foundation, please visit our website at www.dcmfoundation.org. You can email us at info@dcmfoundation.org. Please be sure to follow us on especially Facebook and Instagram, as well as LinkedIn. We have updates regularly. Nice shout out to our social media guru, Sam, who does that work for us. Really great resource there. I just want to say stay safe and be well. Thank you again to our amazing sponsor, Pfizer. Thank you to Dr. Mcrae for joining us tonight. And I hope you all have a great evening. Thank you again. Happy St. Patrick's Day. Take care now.